Good morning, everybody. Today is a special day because today World Kidney Day. So this topic is caring for people, protecting the planet. I would like to kindly invite to consultant nephrologist, Dr. Maithree Fernando to stage, and please, stage is available.
A very good morning to all of you. So today my task is to give a lecture about CKD and its preventive aspects and some of its treatment aspects. Okay, right. Okay. So this lecture is basically was arranged as part of our lecture series by the Nephrology Society for the World Kidney Day. And so our basic idea is kidney health for all. Right, so we'll skip all these and we'll come to the topic proper. So basically, we don't have any, we have a slight idea there are about 164,000 CKD patients in Sri Lanka, and approximately 10% of the population is said to be affected by CKD. And about 200,000 patients are supposed to have advanced CKD. But there are only around 8,000 RRT facilities that are available for patients. So the main idea is to more than you treat a patient at the end stage kidney disease with dialysis or renal replacement therapy, our aim should be to prevent them from reaching end stage. So that is much more cost effective, and that should be the way to go. So what are the methods that we use to detect chronic kidney disease at its early stages? So basically we think that the normal thing that comes to mind is you do a creatinine of a patient, right? So but you have to remember, for the creatinine to rise, significant creatinine to start rise, there should be 50 to 70% glomerular loss for the creatinine to start rising, right? So we see we do kidney transplants, right? So we get the kidney from a live donor, right? So before the kidney donation, the patient has a normal creatinine, right? So after the patient had given up his kidney, right, the patient's GFR drops to 50%, right, from previous. But still, you don't see a rise in the creatinine, right? So our live donor patients, we don't see a rise in the creatinine. So why is that? So that is because the remaining kidney doesn't, there's 50% function already left, so the creatinine doesn't change, right? So the same thing happens to us. So if your kidneys are damaged more than 50% to 70% only, you will see a rise in the creatinine. So this creatinine test is a very late test. If you detect the CKD from creatinine, that's a very late detection, right? So that you should remember, right? So we should have better tests to detect CKD at the earliest onset, right? So the best test that they say is to check the urine albumin to creatinine ratio, right? Albumin to creatinine ratio, right? So previously we did something called microalbumin. The problem with the microalbumin is you only see how much albumin in the urine, right? But then what happens is, if the patient is passing concentrated urine, right, you will have more albumin in the urine. Like you might be thinking that the patient has more albumin in the urine. Or if the patient is passing very dilute urine, then there will be very less albumin in the urine. So to mitigate that problem, what we do is we check the urine creatinine also, right? And we divide that whatever albumin we are getting from the creatinine, so that removes that concentration bias from the report, right? So then we get a report without the concentration. We can neglect that. And if that urine ACR, albumin creatinine ratio, is more than 30, that means the patient is passing significant amount of albumin in the patient. Okay, so that is the best test that you should do. And the other thing you should remember is, when you're doing a urine ACR, you can thing is to do it with the early morning sample, right? So why do you use early morning sample is there's something called orthostatic proteinuria. So we also sometimes when we do heavy work and we walk around and all that and we pass urine, we also see some, froth in the urine. Like there is frothy urine. I also have frothy urine when I work and everything. But whenever I check my urine ACR in the morning, that doesn't have any protein in it, right? So that is the orthostatic proteinuria. Right? So that's why we say, if you're doing a single sample, urine ACR, do it with the early morning. Why early morning? Because all of us, before going to bed, we pass urine, right? So we have an empty bladder, right? So there's no urine in it. When we sleep on a horizontal level, right? We don't sleep sitting up, right? So the urine that is produced during the night time doesn't have the orthostatic effect, right? So if the urine in the morning has protein, that is clearly pathological. Right? So that is why you do an early morning sample and see that protein is there or not. If it is there, that is an early sign of the patient having kidney disease. Okay? Right. So the other tests like the urine protein to creatinine ratio, urine dipstick, UFR, these are actually they detect very high levels of protein. Usually for your UFR to detect protein trace, the ACR should be more than 300 for you to see a trace of protein in your UFR. Right. So there are plenty of diabetic patients with a urine UFR with nil protein. No protein in the urine, in the UFR, right? So you may get a false sense of security thinking that the patient doesn't have renal disease, right? But the UFR is not showing any protein, right? So if you do the urine ACR, you will see the patient is passing protein, okay? So remember, UFR is a very useless test for early detection of renal disease, UFR, right? So don't be happy if the UFR is showing a normal result. So this is the CKD treating heat map. So here, what we have is on the upper part, there is the albumin, right? So the albumin, A1, A2, A3. So that is urine ACR less than 30, that is normal. Then A2 is 30 to 299 and A3 is more than 300. Okay, so that is how you classify the albumin, patient's albumin, albumin in the urine. And here on this side, we have the GFR criteria, G1 to G5, depending on the GFR, more than 90, 60 to 89, likewise. Okay, so now what are the people who we treat? The first, you can see the green color screen, like 1. So those are the people. They are having normal renal function, basically. So the albumin is less than 30, right? Albumin is less than 30. And on the GFR side, it is above 60, right? If the urine ACR is less than 30 and your GFR, estimated GFR is above 60, right? You don't take them as having significant renal disease, okay? So remember that, right? So we get many referrals sometimes, not from here, like from peripheral, let's say like peripheral CKD units from the screening programs, where the GFR is, let's say 70, right? GFR is 70 with a urine ACR of less than 30, right? GFR is 70, urine ACR is less than 30, okay? So those people come into that green box, right? Because they are not producing protein, right? And their GFR is above 60, right? So you don't need to do any treatment for them, right? So other than control the hypertension and all those, but no need of specific renal treatment for those people, okay? So once the GFR goes below 60, right? Or if they have protein, urine ACR more than 30, then only you should treat these people, okay? So remember that, right? GFR is above 60, right? If the ACR is normal, no need to treat. But if the GFR is above 60, but they have protein, then you have to treat them, right? Because they have protein, right? Even if the GFR is normal, but if they have protein production, you have to treat them, right? Otherwise, the same also. If the GFR is less than 60, but they don't have protein, you need to treat them, right? If the GFR is less than 60, but they don't have protein, you have to treat them, right? So remember that, okay? So, so what are the treatment? So there are now basically, now actually this is somewhat outdated. we have 4 pillars of treatment for CKD, right? So these slides were sent by the Nephrology Society. So some of them are a little bit outdated actually, but I will tell you there are 4 pillars of treatment for CKD, right? First thing is basically the ACE inhibitor, right? ACE inhibitor or the angiotensin receptor blocker, okay? ACE and the ARBs, first pillar. Second one is the SGLT2 inhibitors, right? SGLT2 inhibitors, right? Third pillar is the mineralocorticoids, right? Mineralocorticoids, spironolactone, and the newer agent, the firananone, okay, the newer agent, right? And the fourth pillar is the what do you call this Ozempic, right? Ozempic, that is the GLP agonists, right? GLP agonists, right? So that are not yet available in Sri Lanka. That is the fourth pillar, GLP agonists, right? So those are the 4 pillars of CKD treatment. First is ACE inhibitor, ARB. Second one is your SGLT2 inhibitor, right? Third one is your mineralocorticoid antagonist, right? Your spironolactone and the finerenone, right? And the fourth one is your what I mentioned, the GLP agonist, right? So those are the 4 pillars of CKD treatment. Okay, so so how do you go about the treatment of these patients? Is that first you perform the patient's urine ACR, okay? You perform the patient's urine ACR and you do the patient's serum creatinine and you get the estimated GFR from that, right? So eGFR and the urine ACR. So now, as I mentioned in the heat map, if they are on that treatment goal, right, that means the GFR is either less than 60, right, or if they're having urine ACR of more than 30, right? So then you have to start them on the treatment, right? So now what they say is you start them on ACE inhibitor, right? ACE inhibitor with the SGLT2 inhibitor simultaneously, right? Simultaneously, right? Both should be started at once, okay? SGLT2 inhibitor and your ACE inhibitor both start at once, right? So that is the guideline that says, right? Right. So afterwards, you have to repeat the patient's urine ACR, right? So after about 2 to 4 months, you repeat the ACR. If it has come less than 30, that means you have achieved your goal, right? You continue the treatment, right? So if the urine ACR is more than 30, right, that means you have to escalate your treatment, right? So you started the ACE inhibitor and the what do you call the SGLT inhibitor, ACR is more than 30, then you add on, right? So what do you add on? You can add your spironolactone to this patient. Also, you can increase the maximum dose of ACE inhibitor or the ARB to the maximum dose, right? But when you're doing that, make sure you check the patient's electrolytes, right? Because you may develop a hyperkalemia, right? So if that's happening, then you have to come to a like moderate level. You have to balance it, okay? And also other thing is if there's hyperkalemia, you should try to still give your ACE inhibitor to that patient, right? By controlling the potassium by other means, right? So what are the other means? You can add some kind of a diuretic for the patient, right? So when you add a diuretic, right, so what happens is there is, now if you use a loop diuretic, right, so it will be blocking the thin ascending limb of the loop of Henle, right? Then there will be no sodium absorption there, right? So what happens? The sodium goes to the distal convolute tubule. So there we have the sodium potassium ATPase, which actively what it does, it takes in the sodium from the lumen and puts out potassium, right? So that way you can waste the potassium by increasing the distal delivery of your sodium, right? So by giving a diuretic, you can cut down the patient's potassium and you can still continue your ACE inhibitor. It's very important because what we see is when the potassium is 6 or something, many people immediately stop the ACE inhibitor, right? So don't do that. If it is 6, don't worry. You use other means to reduce your potassium, okay? So one is adding a loop diuretic, right? Getting rid of the potassium. Other thing is other reasons for the hyperkalemia may be acidosis in your patient, right? So the patient may be acidotic, right? So what happens is this, if you take intracellular potassium, that has a very high, 144 milliequivalents is intracellular potassium, right? So how does this high concentrated potassium is kept intracellularly and your serum has a 4.5 millimole, right? So that is done by actively pumping the potassium into the cell. What happens is if there's severe acidosis, this pumps doesn't work, right? So that's why the potassium leaks into the out of the cell, right? So by correcting your acidosis, you can activate those pumps and pump your potassium into the cell, right? So correction of bicarbonate, by giving sodium bicarbonate, you'll be able to reduce your potassium and continue your ACE inhibitor, right? So other than just stopping your ACE inhibitor, okay? Right. And yeah, so other thing is you have to basically manage the primary condition. So about the primary condition in Kurunegala district, what we see is about 90% of patients are having diabetic nephropathy. So the reason for the CKD here, 90% is diabetic nephropathy. Okay, so diabetic nephropathy. So now recently the NICE guidelines, the UK guideline, they just updated the diabetes management. I hope all of you are knowing about that. It's very important. The NICE says with the recent cardiovascular data, what they say is if somebody is diagnosed with diabetes, remember this, diagnosed with diabetes, you have to start them on your metformin with EMPA or dapagliflozin at the onset. At the onset, okay? Remember, all diabetics should be on metformin. That also they say a long-acting metformin, like a sustained release metformin, because it's better GI tolerant, right? The patient doesn't have these gastric problems and the loss of appetite and things are less in the long-acting metformins, right? Sustained release metformin, like if you have the glucophage and all that, and these glucophage things are, the glucophage those are actually under price control. One tablet is 15 rupees 10 cents, right? Whatever the drug, the glucophage comes from France, right? So there's a made in France tablet for 15 rupees 10 cents, right? So those are under price control. So that is what they recommend, a long-acting metformin along with DAPA or empagliflozin at the onset of diabetes, right? At the onset of diabetes, patient has not have any complications yet, right? Why they say? That is because they have found overwhelming cardiovascular benefits of giving SGLT2 inhibitors for diabetic patient at the onset, right? What they have is there is a relative risk reduction of 14 to 28%. 14 to 28% of relative risk reduction of a new onset diabetes patient from getting myocardial infarction, heart failure, right? Myocardial infarction, heart failure, relative risk reduction of 14 to 28% if you start the SGLT2 inhibitor at the onset for your diabetic patient along with metformin. Okay, so remember that. So all your diabetics, please start your SGLT2 inhibitor at the onset. Okay, when starting, remember one thing is the problem. One of the problems of the SGLT2 inhibitor is that how it works is it basically blocks the glucose and the sodium co-transporter at the proximal tubule, right? So that's how the SGLT2 inhibitor works. So what happens is when you block the SGLT transporter at the proximal tubule, your glucose is not now getting absorbed, right? So glucose will not get absorbed because you have blocked that, right? So that will increase the glucose excretion in the urine, right? So, you know, glucose is an osmotically active agent, right? So glucose likes to always keep water with it, right? So water likes to stay with glucose, right? So the patient will have a osmotic diuresis, right? So when you start the SGLT2 inhibitor, it's better that first you get your glucose under control, right? So you get your glucose under control, because if there's an uncontrolled diabetic without any proper sugar control, you put the SGLT2 on that, the patient will have severe diuresis. Your diuresis will increase because of the osmotic effect, that there's more glucose now going out because you have blocked that channel. Okay. So before starting, get the glucose under control. So to do that, you use your metformin, use your other anti-glucose agents, right? Once the glucose under control, immediately start your SGLT2 inhibitor, right? This way, the risks of SGLT2 inhibitor, like your recurrent UTI, those things actually, and the dehydration, those complications reduce once you control the glucose and then start the SGLT2 inhibitor, right? That's basic common sense, okay? Right. One word, how actually now the thing is this. Now, before the invent of the SGLT2 inhibitor, for the diabetic nephropathy, we didn't have a specific treatment. The reason is what happens in diabetic nephropathy? So there is glomerular hypertension. right? Diabetic nephropathy is due to glomerular hypertension, right? So we have to find out how this glomerular hypertension happens. So how does it happen? So what happens in diabetes is the patient is producing it is excreting high amounts of glucose, gets filtered into the glomerular filtrate because patient blood sugar is high. The glomerular filtrate from the glomerulus, what comes out has high amount of glucose. Okay. Now this high amount of glucose, when it comes to that proximal tubule, the SGLT transporter, what it does is it wants to reabsorb this glucose, right? So it works over time and reabsorb the glucose. It cannot only reabsorb glucose, it will also reabsorb sodium, right? So there's sodium also getting reabsorbed from the proximal tubule. Okay. Now what happens is after the proximal tubule, the sodium concentration of the glomerular filtrate reduces, right? Because most of it is absorbed at the SGLT at the proximal tubule, right? Now there are sodium sensors at the distal tubule. So these sodium sensors, the idea is to sense the sodium in the tubule, and if the sodium is less, it's reduced, the body thinks that the patient is dehydrated, right? Because that is a protective reflex. That was called the tubular glomerular feedback loop. Tubular glomerular feedback, TGF, tubular glomerular feedback loop. The idea is if somebody is bled or had severe diarrhea or vomiting, whatever, if the patient is having a hypovolemic state, the filtered amount of sodium will be less because there's low blood pressure or whatever, right? So there's reduction in the glomerular filtrate sodium, right? So now this sodium is sensed at the distal sensors, distal tubule. There are sodium sensors which are sensing the low sodium. And it tells the body there's less sodium coming in. The patient may be dehydrated, right? Kindly increase the afferent arteriolar tone. Reduce the afferent arterial tone so that more blood is coming to the glomerulus, right? So more blood coming to the glomerulus to maintain the GFR, right? To maintain the GFR. You understand that, right? So if there's hypovolemia, what happens is there's less sodium coming into the glomerular filtrate, right? So this less sodium gets detected at the distal tubule sensor, right? Distal tubule sensor says less sodium, the GFR is reduced. We have to maintain GFR because we have to clear the solutes, we have to clear the acids, everything. We have to maintain the homeostasis. So how can we increase the GFR? So the glomerulus has the blood coming into the glomerulus by the afferent arteriole. Afferent arteriole feeds the blood to the glomerulus. So if you dilate the afferent arteriole, what happens? There's more blood coming into the glomerulus, right? So then the GFR will be increased, okay? So that is the protective mechanism. In diabetes, unnecessarily this protective mechanism gets activated. So how it gets activated? As I told, because of the high sugar, the SGLT channel reabsorbs unnecessary amount of sodium, right? So now the distal sodium is reduced. Body thinks patient dehydrated. It opens up the afferent arteriole. So more blood now rushes to the glomerulus. That increases the glomerular hypertension. That causes the glomerulosclerosis. Okay. So this is the mechanism of diabetic nephropathy. Okay. So previously what we did was there's more blood coming into the glomerulus. We had an outdoor, that is the efferent arteriole, the blood coming here, efferent arteriole sends the blood out. We just open the efferent arteriole, right? So that way the glomerular pressure reduced. How do you open the efferent arteriole? We gave the ACE inhibitor and the ARB, right? ACE inhibitor, ARB opens up the efferent arteriole, dilates the efferent arteriole, right? So the glomerular pressure reduced, but we didn't address the primary pathology. Primary pathology is that what I mentioned, right? So this SGLT inhibitor is the only drug which affects the primary pathology of diabetic nephropathy, right? So that is why it should be given in your diabetic patient, okay? So remember that, right? All diabetics should be on SGLT2 inhibitor plus metformin at the onset, right? Mainly because of the cardiovascular data, the renal data, the Crendon study, 2018, we had the Crendon study that was done mainly with the pathological patients, like only patients with increased amount of proteinuria or patients with high creatinines, right? But currently we haven't had any studies done on normal diabetic population, normal patients without renal disease, we haven't proven the benefit in a study wise. We haven't proven the benefit of SGLT inhibitor from a renal point of view, right? So renal point of view, if a patient with diabetes at the early onset of diabetes, I mentioned, the patient doesn't have renal disease. GFR is normal, right? ACR is normal, right? But renal evidence doesn't point to start SGLT inhibitor at the onset of diabetic diagnosis, right? But the cardiovascular studies have shown benefit of SGLT inhibitor at the onset of diabetes. That is why we are starting the SGLT inhibitor at the diabetes onset, okay? Not because of renal evidence, right? But though the studies were not done, if you do a study in a diabetic patient, right? Clearly, I think there will be benefit from the onset. If you start SGLT inhibitor in a diabetic patient, there will be really benefit, renal benefit definitely will be there because of the pathology getting disrupted, right? The patient will not develop renal disease. It will take more than long time to develop it, okay? But the evidence is only there for the cardiovascular benefit at the onset, right? Okay. Right. So yeah, basically diabetic glycemic control is very important. So you should aim, depending on the patient's comorbidities and the age and the life, how much life is left in the patient, your HbA1c goals should be titrated, okay? So young patient, active patient, you try to come to a less than 6.5 or less than 6 HbA1c goal for young people with diabetes, right? Very elderly people, less life expectancy, your HbA1c goal may be a little bit up, okay? But what we have seen is, in my practice, if you titrate your glycemic control to less than 6.56, if the patient has a GFR of less than 30 even, if they have proteinuria, we have been successfully able to reduce the proteinuria, usually to get it less than 30 by combining them with a very tight glycemic control and the treatment with SGLT2 and the ACE inhibitor and all that, right? So that can be done, right? So we do that in our clinics and our other practices. Okay, so glycemic control is a very important thing. So please remember to have a tighter glycemic control of your diabetic nephropathy patient, right? That really helps. Okay, so there's no point in having HbA1c of 8, right? And giving you a SGLT inhibitor or the ACE inhibitor and hoping the patient's kidney will get cured, right? The primary problem is there, right? Without addressing the hyperglycemia, right? There's no point in giving you there is a benefit, but you don't get the full benefit, okay? Another thing is in our medical clinics, what we see is we do only fasting blood sugar, right? I mean, basically because of the, what you call the lab constraints and everything, we see the patients are only getting fasting blood sugars. The problem with the fasting blood sugar is it checks your fasting state, right? So we are not like challenging the pancreas, right? So because diabetic is like the pancreas is not active properly, right? There's resistance, right? Insulin resistance. So we have to test this organ by giving a challenge, right? So the challenge, it should be challenged. If the organ is in a resting state, right? A patient is fasting for 6 hours, 8 hours, right? And you check the fasting. Most of the patients, your fasting is normal, within normal, 90, 100, like that. But if you do a PPBS of this patient after a challenge, that is sky high, right? And if you do HbA1c of your patient, HbA1c, that will give you the average of the 3 months, right? That is again sky high, 8, 9, right? But the fasting is 100, right? So our medical doctors, we are happy. We are thinking the patient has good control. There's no good control, right? So please do HbA1c test, right? And that way you get a proper idea of your proper sugar control status, not just the fasting blood sugar, right? That is really important. The American Diabetic Guideline really emphasizes this, right? Never to do only fasting blood sugar. Always do the HbA1c, right? And also the postprandial blood sugar. Postprandial blood sugar, because you have to challenge the organ, not just get a fasting value, okay? Right, and then and reduce that to the desirable effect, right? HbA1c less than 6.5, fasting blood sugar of at least 80 to 110, right? And the PPBS, 2-hour PPBS, 80 to 140, 80 to 140. So try to keep it in that range. And the other thing to tell you guys is the AD, American Diabetic Association, they had recently revised their insulin therapies. They have banned mixed insulin. ADA guideline bans. In America, they have banned your mixed-start insulin. M insulin is banned in USA. I think all our patients are on mixed-start insulin for diabetic management. That is a banned drug in the USA, right? Remember that it is banned. Why did they ban it? Their rationale for banning the mixed-start 30/70 mixed insulin is this, right? One thing is mixed-start is 30% soluble, 70% isophane, right? Soluble is the fast-acting insulin, isophane is the intermediate-acting insulin, right? So when you give mixed-start, now the problem with your diabetic patient is, patient has two problems. One is there's basal hypoglycemia, right? So basally there's a high sugar level, right? And they have postprandial hyperglycemia. So after they eat, right? After a maximum of around 2 hours, there's a peak sugar level rises up, right? After eating, after about 2 hours, right? So there's a basal deficit of insulin and there's a postprandial sugar spike is there. To control that, there's a deficiency of insulin again from the pancreas to reduce that, right? So we have to address both these problems, right? You have to treat the basal hyperglycemia as well as the postprandial hyperglycemia, right? So in Sri Lanka, we take 3 meals, right? Usually everywhere in the world, they take 3 meals, right? So then there will be 3 sugar spikes, right? 3 sugar spikes, right? Breakfast, lunch, dinner, right? So if you give your mixed-start insulin, it only has 30% of soluble, fast-acting. Only the fast-acting will be beneficial for the postprandial sugar spike control, right? So basically, you need to have a soluble insulin for your postprandial sugar control, right? So when you use a mixed-start, you are having 30% soluble at the breakfast, but there's no soluble for the lunch, right? So that is why the lunch ppbs is high and the average HbA1c never gets controlled because your lunch postprandial is sky high, right? And when you take the dinner also, there is a small amount of soluble insulin that is covering the dinner because there's 30% of soluble. But what happens is now, if you are targeting your ppbs, the breakfast ppbs or the lunch ppbs, you have to increase the dose of mixed-start. So you have to give a big dose of mixed-start because there's only 30% of soluble that controls your postprandial. Okay. So to control that spike, you are giving a high dose of mixed-start. Let's say 30, 40 units of mixed-start. So what happens is 70% you are giving is isophane. So all your patients on high dose mixed-start, 40, 30 units, are all hypoglycemic in the evening. You ask them, they are very much hungry. 5 o'clock, 4 o'clock, they are eating up very much because of the hypoglycemia towards the evening because of that high mixed-start dose. And when you see the fasting in the morning, it is well controlled. Because why? Because you are giving 70% of isophane in the evening dose, right? 70% isophane is a long-acting, intermediate-acting insulin, which will nicely control your fasting blood sugar. So the clinics, we are very happy with mixed-start, right? That is the false sense of security we are getting. You understand that, right? Because mixed-start has a high amount of isophane that will nicely control your fasting blood sugar in the morning, right? But the postprandial sugars are never controlled, right? So that is why your HbA1c is high and the patient develop complications. Cardiac, eye problems, renal, everything happens to the patient. But patient is on insulin, right? So that is the irony of this, right? So that is why they ban mixed-start, right? So that is the thing. So please take that message home. Try to go for basal bolus regime. That is what they recommend, right? And that has evidence because it only reduces the HbA1c to a reasonable degree. Okay. Right. So blood pressure control. So now diabetics without CKD, the target blood pressure is 130/80. Right. Target is 130/80. Systolic blood pressure 130, diastolic 80. For diabetics without CKD, but the patients with CKD, the guideline says blood pressure target is less than 120/80. Okay, less than 120/80, right? So this is without CKD. With CKD, it should be less than 120. And the first, like the antihypertensive, when you choose for a diabetic patient with hypertension, that should always be ACE inhibitor or ARB, right? For diabetic patient, if a diabetic has hypertension, right? The primary first drug you start should be a ACE or ARB, right? Not any nifedipine or anything, right? First drug should be for diabetic with hypertension is ACE inhibitor or ARB, right? It's very important, right? So do that. So SGLT2 inhibitor, I think I talked a lot about this, right? So I think we'll skip that, right? So you can stop it like in periods of, let's say, dehydration, right? If the patient is dehydrated and the patient going for surgery and all that, you can just briefly stop it, the SGLT, and then restart it afterwards. So lifestyle modifications, we all know, but these are also very important, like smoking cessation, dietary intervention, right? And a moderate amount of physical activities. Lipid management, yeah, this is also something that got recently revised. Lipid management, for lipid management in CKD, right? So if you have a patient with CKD, right, the lipid management, what they say is LDL goal less than 70, right? Clear cutoff, LDL less than 70 for diabetic patient with CKD, right? So remember that, right? Diabetic patient with CKD, with hypertension, CKD, the LDL goal is less than 70. Okay. If the diabetic patient or non-diabetic patient with ischemic heart disease, already diagnosed ischemic heart disease, right? Without or with diabetes, LDL goal is how much? Less than 55. Remember that, right? Less than 55, right? Diabetic patient with ischemic heart disease, right? With or without diabetes, whatever, ischemic heart disease, secondary prevention, LDL goal should be less than 55, right? Right? Less than 55. And diabetic patient with CKD or hypertension, LDL goal should be less than 70. Previous it was 100, so it has come down to 70. For dialysis patients, currently we don't have evidence of cardiovascular benefit from statins, right? So it is up to you to start or not, right? Dialysis patients, right? Yeah, so a little bit about this one, the more mineral bone disease. Now, previously, when we were house officers, we were told all CKD patients start calcium carbonate and 1-alpha, right? So this is now no longer there, right? So we don't do that, right? So now the thing is, remember this, the 1-alpha, the active vitamin D3, right? Active vitamin 1-alpha, cholecalciferol should only be started at a nephrology unit, right? Only be started at a nephrology unit. That is the latest guideline. 1-alpha should only be started by a nephrology unit, either trained nephrology MO or by the nephrologist, right? Why? Because 1-alpha should only be given after testing PTH in your patient, right? 1-alpha is no longer used, right, without checking your PTH. Okay, so remember this. Why? Because the multiple studies have shown unnecessarily giving 1-alpha has calcified blood vessels, right? It calcifies blood vessels, right? Calcifies blood vessels. Patients grow into a premature atherosclerotic disease, not because of because of the lipids, because of calcification of the coronary arteries, right? And these calcified coronary arteries cannot be stented also, because they are like cemented coronary arteries. If you do the ballooning, they rupture, right? So it's a very serious condition. So don't use 1-alpha without taking PTH in your patient. So if you use 1-alpha, you can use it. Everybody can use it. You do the PTH, right? PTH. You do the PTH, parathyroid hormone. The target when you should start 1-alpha is the PTH is above 63. Then you can start 1-alpha. PTH more than 63, then only you can start 1-alpha. Okay? Do the PTH test, right? If it is more than 63, start 1-alpha. Okay? Then titrate the dose. You recheck the PTH 3 monthly with the calcium and the phosphate, and you titrate your dose, increase it. You can start with 0.25 every other day, like small dose, then titrate upwards. Now, let's say when you do the PTH in your patient, it is 200. Okay, so it is clearly above 63. Okay, so we start 1-alpha. For a 200, we'll start actually 0.25 daily, right? If it is, let's say, 140, you can start 0.25 every other day, likewise. 3 months, recheck it, then increase the dose of 1-alpha. That is how you give 1-alpha. Everybody else don't start 1-alpha without taking PTH, because it does more harm than good, right? More harm. You cause the patient to have a heart attack. Okay, right. The calcium binder, right? The phosphate binder. Phosphate binders, we have the calcium-based phosphate binder and the non-calcium based. In Sri Lanka, we have the calcium based one, because it's very cheap, right? The calcium carbonate. calcium, the carbonate is the phosphate binder, right? So this calcium carbonate should only be used if the patient has hyperphosphatemia, right? Patient has hyperphosphatemia, then only you use your calcium binder, okay? So not for all the CKD patients, okay? Remember this, right? Not for all CKD patients, only patients with hyperphosphatemia. And the target phosphate is now should be more than 5 milligrams per deciliter. Previously it was 4.5. Now treatment dose should be at 5 milligrams per deciliter, right? So start the calcium carbonate if your phosphate is more than 5. Okay, phosphate more than 5. Yes, go ahead and start your calcium carbonate. When giving calcium carbonate, remember, they should what? They should just drink the tablet or they should chew the tablet. They should chew the tablet. Calcium carbonate should be taken before meal, right? And it should be chewed. Okay. So if you are giving one tablet, we are starting with one tablet and titrate upwards. So what is the largest meal we are taking as Sri Lankans? We take our lunch as the largest meal. So calcium carbonate should be given before lunch. It should be given before lunch and should be chewed before eating. Then if you are adding another tablet, still the phosphate is high, more than 5, you have to increase the calcium carbonate. Then you put that second tablet with the second largest meal. So what is that? That is the breakfast, right? So that should be breakfast and lunch, okay? Not breakfast and dinner, right? So it should be lunch, first tablet lunch, second tablet breakfast, third tablet maybe dinner, likewise, okay? So that is how you go with the calcium carbonate. And the other thing is monitor the calcium when you start the calcium carbonate because calcium might go up, right? So again, if you have a high calcium, again, the calcium phosphate product, the calcium erythema, the phosphate, that goes up. If it is more than 5.5, again, the vascular calcification will happen, right? So then if the calcium is also going up because of your calcium carbonate, you should stop that calcium carbonate and use a non-calcium phosphate binder, which doesn't have calcium, right? So there are non-calcium phosphate binders, right? What are those? Those are lanthanum carbonate, right? Lanthanum carbonate and the sevelamer. So those are the non-calcium. They don't have calcium. They will reduce the phosphate without increasing the calcium. Okay. Only thing is they are a little bit expensive, not available. The calcium, the lanthanum carbonate is available as a name patient basis at the MSD. You can get it for your name patient basis. Okay. So remember that, right? So calcium carbonate only give if the phosphate is more than 5 milligram per deciliter and titrate the dose. Okay. And never give it for blindly without checking that, right? But phosphate is an easy test, so do that and then you give the calcium carbonate. But 1-alpha should be given only if the PTH is high. Okay. Not empirical 1-alpha treatment. You will do more harm. Okay. Right. Yeah. The other thing is this vitamin D deficiency. Slightly touch on that. So in Kandy, Dr. Nishant Narakar, one of our senior nephrologists, he did a study of vitamin D in Sri Lanka. So what the target population, what he checked was the farmers, right? The farmers without a shirt or nothing, bare chest, they are doing farming. He checked the vitamin D of the farmers. So the funny thing was the vitamin D, they were deficient. The farmers are deficient of vitamin D in Sri Lanka. Okay, so then there's a thing like whether we don't know, like due to our ethnicity, I don't know whether we need lesser levels of vitamin D compared to the Caucasian people, because these normal levels were standardized for the Caucasian people. So I don't know, because now we have been doing farming all this time when we have never been taking vitamin D. But so whatever it is, if you take that whatever range given in the test, the farmers are deficient, right? So what they say is all CKD patients, because there's a problem of this, the vitamin D deficiency happening because the activation of 1-alpha happens in the kidney. They say to top up the natural vitamin D level should be topped up, right? Not the 1-alpha. The cholecalciferol should be at a normal range of the CKD patient, right? So all CKD patients, it is advised to have a normal vitamin D level, right? Normal vitamin D level for all CKD patients, okay? So that is important. So we also did a lot of vitamin D testing in our patients. We found all of them were deficient of vitamin D. So they had a like normal range was about 30 to 100. So they were usually at the range of 10 to 20 line, right? So when you check the guideline for treating vitamin D, they recommend, what is the recommendation? 60,000 units weekly dose. 60,000 units vitamin D, 60,000 weekly dose. If it is less than 10, that is severe deficiency, 5 weeks. Right, so 5 tablets of 60,000 weekly 5 tablets. That should clear the deficiency of less than 10. So from 10 to 30 range, they recommend like up to 3 tablets to 4 tablets dose weekly, right? So what we did was actually we gave about 3 weeks of vitamin D for all the empirically for all CKD patients, first time only. Previously not given vitamin D, we gave 3 tablets of vitamin D. And we checked the after the 3 tablets, all were within normal range. Right? So they were all within normal range, above 30, 40 like that. Nobody was toxic. Okay. So what we recommend for the Sri Lankan population, because vitamin D testing costs about 10,000 rupees in the outside. So you can't be doing vitamin D testing for everybody to give vitamin D. So the practical approach for our people is give 3 tablets of 60,000 for 3 weeks. Okay. 60,000 units, 3 tablets, 3 weeks. That will clear the deficiency in most of them. Right? Then you put them on a 1,000 units per day maintenance of vitamin D. 1,000 units maintenance of vitamin D. Now, again, giving the maintenance, there's a budget-friendly way. Because vitamin D is a fat-soluble vitamin and it has a very long half-life, right? Some 6 months to 1 year of half-life is there in the body, right? So no need of giving daily 1,000 units. That tablet costs about 35 rupees. 1,000 units of vitamin D, 35 rupees. So that's the additional expense of the patient. You just give 60,000 units for 2 weeks. 60,000 for 2 weeks. That means 1,000 per day, right? So very easy. 60,000 tablets is 125 rupees. Oh, very, very, for 2 months. 2 months. 60,000 tablet once every 2 months, right? Once every 2 months, if you give 60,000, effectively you are giving 1,000 units per day and very budget friendly, right? So that is the approach we are using in our nephrology practice. So we give 3 tablets of 60,000 weekly for 3 weeks. Then after the last day of the 3 tablet, we tell them take 60,000 every 2 months, or otherwise every other month, right? Skip 1 month and the other month you take it, right? So that way you will maintain a good vitamin D level. That will actually help your bone health, and your PTH will not go up that much because you are giving a normal level of vitamin D, right? So the PTH, you don't have to use much of the 1-alpha also if your vitamin D is within the normal range, right? You can mitigate the use of 1-alpha, right? And doesn't have complications, okay? Right. So CKD anemia, again, CKD anemia, thing you have to know is the target anemia cutoffs are the same as normal population. Males less than 13 is anemia, females less than 12 is anemia. Okay, so if somebody has CKD and the HBs are lesser than that, first what you do is you do the iron study, right? So you do the iron study, you do either ferritin or the transferrin saturation. Okay, so if the patient is having anemia less than 13 for male, less than 12 for female, do the iron study, ferritin and transferrin. So the target first thing to treat the anemia is to get the iron level to the expected level for CKD. What they say is CKD is a relative iron deficiency state. CKD is a relative iron deficiency state. Compared to the normal people, the CKD people need a higher iron concentration for them to produce hemoglobin, right? CKD people need a higher iron concentration compared to the normal population, right? So the target ferritin levels are much higher for the other people, right? So normal ferritin for a normal person is, I think, around 45 to 85, something like that. Our fellows need at least 350 to 500 of ferritin. CKD patients, for the proper erythropoiesis, ferritin level is 350 to 500, right? 350 to 500, very high, right? So let's say now normal person becomes a CKD patient. You know, he's a previously normal person having a normal ferritin level. Let's say 35, 40, something like that. Now patient becomes CKD. Now, because of the CKD, nobody is giving him an extra dose of iron to the patient. So the patient becomes iron deficient, right? So the first treatment in iron deficiency, our CKD, you correct the iron level for this new supratherapeutic level, right? 350 to 500 of ferritin, right? So either you can give oral iron, or if you want to give it quicker way, you give the IV iron, right? Get the ferritin to above 350 to 500. Then most of your anemia will correct by correcting the iron level, right? Remember, it's a higher level than your normal person, right? Then still, once you achieve that ferritin of 350 to 500, if the patient is still anemic, right? Still anemic in the sense if the HB is less than 10 only, right? If the HB is less than 10, now you are given patient iron. You have saturated the iron to the new level, right? 350 to 500 or the transferrin saturation of more than 30%. Now patient is still anemic, but the cutoff now changes, not the 13, 12 now. Now the cutoff is less than 10. If the patient is less than 10 HB, right, with a saturated iron, now you start the erythropoietin. So that is where you start the erythropoietin, okay? So remember that, right? So first you correct the iron, right? Iron is corrected now. Still the HB is less than 10. Now you start the erythropoietin. Okay, so there one small practical problem in Sri Lanka doing this. So that is now when patients come to us, they come in very advanced CKD, right? GFR is less than 10, 12, right? So these people, they have already developed actually the erythropoietin deficiency. Now they have iron deficiency also, right? But they also have erythropoietin deficiency. Now in the UK and places, they regularly check the HBs of these CKD people. So when they become anemic, they quickly check it. So they detect that they are the iron deficiency, they treat the iron, HB comes up. Now creatinine is still at the upper levels, GFR 40, 30, likewise. Still the erythropoietin deficiency has not started in these people. So for the people with a GFR of 30, 40, by just correcting the iron, you can get the HB up, right? But if you take a patient with GFR of 12, 10, very low GFRs, right? Only correcting iron, you will not get the HB above 10. You understand that, right? Because they have, in addition to the iron deficiency, they have erythropoietin because they have advanced disease, right? So if a patient with HB 6 comes to us, HB 6, right? GFR is 12, right? So according to the guideline, we are only giving now IV iron and getting the ferritin above 350, 500. That will take 1 month or something, right? So if you wait for 1 month to get the iron, definitely your HB will not go above 10 because patient has erythropoietin deficiency. So practical purposes in Sri Lanka, when an advanced CKD comes with a GFR of less than, let's say, 15 or something, with a very low HB, right? We simultaneously start the iron therapy as well as the erythropoietin treatment, right? We don't only wait for the iron to come up and then later at the erythropoietin because this takes unnecessary time. Patient will be unnecessarily anemic for a longer duration. You understand that point, right? But in UK, that doesn't happen because they are very well checked, very frequently checked. Early iron deficiency detected, it is treated, HB comes up, and they maintain the iron. They maintain the ferritin of 350. Then later on, they see once the GFR declines, now the HB slowly declines. Now they know clearly this is erythropoietin deficiency because they have already corrected the iron, right? Now they add the erythropoietin, then the HB comes up, right? But our place, we don't have that strict monitoring, right? So that is why very low HBs, advanced CKD, we give iron as well as erythropoietin at the beginning, right? So that is a practical aspect in our practice, right? Okay. Yeah, this is a metabolic acidosis. We have to, the thing is metabolic acidosis, again, is very important to prevent the CKD, right? So your CKD patient, do the bicarbonate level in the patient. Bicarbonate, usually the bicarbonate, the acidosis happens in the advanced disease, not the early disease, right? Advanced CKD, check your bicarbonate, right? Bicarbonate, that should be maintained at least about 20, at least 20, 22. If you maintain it, it has shown to reduce the progression of CKD. If you maintain the bicarbonate about 22, it will reduce the progression of CKD, right? So what this is, when the patient is acidotic, there is intrarenal vasoconstriction because of acidosis. Acidosis causes intrarenal vasoconstriction, right? So there's lesser blood supply to the kidney that increases the CKD progression, right? So treating bicarbonate, giving bicarbonate and correcting the level will give you, will reduce the progression to end stage and dialysis. Okay, so it's a very important thing. And it also increases the appetite, the weight loss, all those things will improve once you correct the acidosis in your CKD patient. Yeah, so basically you have to follow up with your creatinine and the ACRs and titrate your doses of ACE inhibitor ARBs. So yeah, okay. Yeah, so these are the things where you have to refer. Like if the GFR decline is more than 5 ml for 1 year. If the rapid GFR decline is there in a patient with CKD, better to refer that patient because there may be other things we should consider in correcting. Okay. Yeah, so these are like, yeah, so there are some audits you can do in your clinics. HbA1cs and all this you can check in your clinic, blood pressure targets, all those. Yes. Okay, so thank you so much. Yes. Any questions? Pardon, empagliflozin for? Without high blood sugar. Yes. If you have CKD, you should start empagliflozin. And if you have this heart failure, the cardiovascular indications, you can start empagliflozin. Yes. And the role of empagliflozin is not to control sugar. And also it is safe for non-diabetic patients because it has very mild sugar reduction. That too is done through the glomerule, the blocking the SGLT, right? So the serum glucose doesn't reduce, right? So you can safely give them.
Ultrasound scan, the role of ultrasound scan in perspective of diagnosis of kidney disease comparing with that ACR.
Yes. So ultrasound scan actually doesn't have basically in the CKD, the kidney patient, the main use of the ultrasound scan is to exclude obstruction, right? So main thing is to exclude obstruction. So we because when somebody comes with a high creatinine, right? Our main idea is to see whether there's obstruction. So if the obstruction, we have to send to the urologist, right? For the kid and the other idea for that is the basic idea to exclude obstruction, exclude any residual volume, the PVRV, the bladder wall thickness, all that, the obstructive thing. Once you exclude that, then the use of the ultrasound is to see whether, I mean, let's say like we are planning a biopsy in a patient, so see whether it's a biopsyable kidney. Now, if it's a small shrunken CKD kidney, there's no point in doing a renal biopsy. So we don't do the biopsy in the small shrunken kidney. So exclude that, we do the thing. And it basically, we use as like a confirmation to see whether this is CKD. And but there's a role for the acute kidney injury. If somebody comes with high creatinine, somebody comes to us, high creatinine. Patient has not had any previous creatinine records in the patient. No creatinine records. Our patients don't have creatinine records usually. They just come without anything. When we do the creatinine, it is high, right? Now we have a question whether this is a AKI or this is a CKD, right? So that instance, we do the ultrasound scan. So it will show whether the kidneys are small and shrunken, then it is CKD, right? But if the kidney is normal size and normal CMD demarcation, likely a AKI or swollen kidney, right? Then we know it's AKI. Then we have to treat the AKI because we can prevent it from worsening, right? So that is the main objective. For the CKD diagnosis per se, but you can diagnose it. It's a confirmation, like high creatinine. If the small shrunken kidney, you can diagnose CKD. But for treatment-wise, not much of a role for the ultrasound scan. Yes.